Hi, my name is Darius Fields, and this is my recording for my Capstone project at Winston-Salem State University in Adult Nursing 2. I'm going to switch over to share my screen, that way we can follow along together. All right, so for my capstone project, I chose to focus on nursing care of clients with alterations in neurosensory perception, use of functional electrical stimulation and therapy. Basically, I wanted to look into other ways to treat these patients that have traumatic brain injury, stroke, um, or spinal cord injuries. The objectives of this course is to introduce transelectrical nerve stimulation, explain how TENS therapy works and its different applications, and educate on the appropriate use of TENS therapy in neurological focused care. And I wanted to include the indications for use and the use of the TENS therapy, safety, making sure we can do so safely. Um, my project rationale basically revolved on just making the nurse's tool belt just a little bit bigger, allowing us to have something else that we could use to help take care of our patients that come in with neurological issues, knowing that those issues tend to be quite subjective and that it's hard to anticipate what's going on and what's wrong with them. So that was the purpose of this, is to just introduce another way that we can help take care of our patients that have neurological deficiencies. So what is functional electrical stimulation? Functional electrical stimulation activates muscles in a series. It goes from one to the next to the next. So basically, with functional electrical stimulation, it mimics the muscle activation that's required to, say, move an arm or move a leg, and it kind of helps to reintroduce that neural pathway to the brain so that the person can recover quicker. Transcutaneous electrical nerve stimulation is another form of functional electrical therapy. But the difference in this one in the FES unit is that this focuses on batch firing. Basically, it has an impact on all the muscles that is attached to it at the same time. It doesn't necessarily have a way that you can program it to fire in sequence. You can adjust the intensity and the duration of the pulses, but that's as far as you can go with those specifications. One study that I read was a double-blind study comparing the TENS unit and the FES unit side by side, and basically seeing which one or how each of them would help someone with a spinal cord injury. So this study was a double-blind, randomized crossover study trial. So basically, you had Group A and Group B. Group A will be on the TENS unit to start with. Group B will be on the FES unit. And between the two of them, they would assess the patients before treatment, an hour after treatment, and 4 hours after treatment, and finally 24 hours after treatment. And from those results, they were able to collect data. Both those Group A and Group B were both exposed to the TENS in the FES unit, just depending on which one you started on first. If you started on the TENS, you would transition to the FES unit, and vice versa. This was a good study. It really helped to shed light on the fact that electrical stimulation is good to help reduce spasticity in those patients that are having muscle spasms from a spinal cord injury. It works in both cases, and it's actually about on the same playing field. The biggest problem that this study had is that it was too small. There were only 10 participants in the selected for the study that met the qualifications, and those 10 patients, they all had great results. And we know that there's always variability and there's no 100% answer. So having more people would allow this study to be more well-rounded and have a better chance for standing on its own. And in order to do so, it needs to be introduced to other places and other people. This study could be introduced to a teaching facility, and it may actually help bring more light to this study and bring more people to this trial. The next study was specifically focused on patients that were victims of strokes and dealing with dysphagia and swallowing difficulties with dysphagia. So what they did in this study was they would apply the TENS unit to the patients while they were going to occupational therapy. And out of that hour-long session, they received 20 minutes of intermittent TENS therapy as well. The intensity and pulsing was all selected based on what the patient was able to handle, and what their level of comfort was. But in the end, the patient showed great improvements. Again, though, like the first study that I looked into, there wasn't enough participation. They only had two patients in the study. And with only two patients in the study, granted, they had amazing results. I mean, they were able to swallow saliva without any issues. They were able to swallow thin liquids in some cases without any issues. The study group was too small for this to be considered associated norm and to be considered for evidence-based practice. This really needs to get into the hands of some other facilities and some other capacities so that we can start working on this on a larger scale, because if it worked for two people, there's a great possibility that it may work for others, and it's worth some consideration. And lastly, I looked into a study that was talking about the future of TENS therapy. Basically, where FES and TENS differ is the way in which the muscle is activated. So if we could get a TENS unit that would activate the muscles in series or in sequence rather than all at one time, it would be more beneficial for a patient that is attempting to relearn to walk or needs gait modification. And that's exactly what this company is doing. They're working on developing a technology that mimics the strong side on the weak side. So if the person has hemiparesis, it'll work off of, it will take the movements of the strong side and mimic it on the weak side, and give that person better control of their body. While this study didn't have any participants in it yet, it does show that there's some promise in the future for this technology to be used and to help people progress with spinal cord injuries and neurological deficits. So for a nurse, what does this mean? It means that we want to learn the limitation of sensory deficits of the patient and establish baselines for their care. We want to look at everything that they have going on. We want to assess them with the NIHSS stroke scale, do a detailed sensory assessment, whether the patient has sensitivity to sharp or dull, or if they can only feel a heavy touch versus a light touch. If they have muscle spasms, how bad are those muscle spasms? And we can measure those with a modified Ashworth scale, which basically determines whether that patient is having severe spasms with rigidity or if they're having none whatsoever. And those are the tools that we would use to assess those patients leading into the diagnosis, where we would develop a nursing diagnosis based on what we want to look for in that patient or what we want to fix, knowing that these patients could be at risk for injury related to neurosensory deficit. Not only do we want to look at what our nursing diagnosis is, we need to know what the medical diagnosis is that caused them to be in this situation. So we need to know whether they had a stroke or a spinal cord injury or TBI, so that we can know what to expect and how soon we can expect to see the type of results that we're looking for. The desired outcome is going to be a combination of increased sensitivity and during the tactile reassessment. We want to make sure that we can see a physical change, and it's also important to consider what the patient sees as beneficial as well. We want to talk to the patient and find out if they felt like they could feel things differently, or if they could feel warmth or cold or whatever the sensation is that you're trying to elicit, to see if they could feel those things differently. And that will help guide our care from that point forward. After we know what the diagnosis is, we will go into a planning phase where we're able to see if that patient is appropriate for TENS therapy. Some spinal cord injuries and strokes are to the point where electrical stimulation therapy may not work. There are no absolutes in medicine, and that's something that we should all be aware of as nurses. Anticipating the level of intensity and duration of therapy is something we should also plan for, knowing what the patient was able to tolerate in previous therapies sessions and what the patient actually needs, where what level they're able to feel these sensations. The last thing we want to do is look into the timing of the therapy. Is it too soon to start the stroke patient on TENS therapy? Is the patient's brain still recovering? We don't want to slow it down by introducing something else for the brain to focus on while it's trying to heal. We also want to look at the application of leads and monitoring for adverse reactions. Want to make sure that we're being safe and that we're not irritating the skin with the adhesive on the leads or causing irritation to the skin from the electrical impulses, or burning the patient. And last but not least, we want to evaluate what we've done. Did it work? How well did it work? Do we think it'll work next time? And establish some benchmarks moving forward. I really enjoyed doing this project, and I think that in the future it'll help us to be able to better care for our patients that have neurosensory disorders. Thank you for your time. Have a great day.